Assalamu alaikum everyone. My name is Ibrahim. I'm a third year medical student, and today we're going to be discussing most of POD pharmacology for your midterm. It will be including the cell wall synthesis, protein synthesis, and anti-metabolites. Don't look at the amount of slides. I swear these are just transition slides. We're good to go. Okay, so let's start with the first lecture, cell wall synthesis inhibitors. Cell wall synthesis inhibitors, how I like to think of them, how they actually are either beta-lactam drugs or non-beta-lactam drugs. Non-beta-lactam drugs are vancomycin, the only thing that we've mentioned in the lecture. So the beta-lactam drugs contain something called a beta-lactam ring, and if it has that ring, it's called a beta-lactam drug. So how do these drugs work? Now you know from Dr. Hana's lecture that the last step of the peptidoglycan synthesis is where the wall has to be cross-linked, right? And this requires an enzyme known as transpeptidase or penicillin binding proteins. This drug works by binding to that enzyme and irreversibly inhibiting it, which means that it can't cross-link. The wall can't cross-link, and the wall would be fragile and it would burst and all the fluids would just leak out. So it would kill the bacteria. So antibiotic. Peptidoglycan cell wall is unique to bacteria, meaning that us humans do not have it. So it's not toxic to us, only toxic to bacteria. And this is just for the sake of completion that beta-lactams also trigger autolysis. Now, the beta-lactam drugs, now that we know the mechanism of action, let's get into the actual bulk. What are the beta-lactam drugs? We have penicillins, cephalosporins, carbapenems, and monobactams. So let's start with the penicillins. The penicillins have a distinct structure. They have a thiazolidine ring, a beta-lactam ring, and side chains. You don't need to know the thiazolidine ring. You just need to know that they have a beta-lactam ring, making them a beta-lactam drug, and they have the side chains. Now, let's look at a picture first because I need to visualize this. We have the side chain, we have the beta-lactam ring, and we have the thiazolidine ring, right? The side chain is what determines the antibacterial and the pharmacological characteristics of a penicillin. So let's say if they have a long side chain, that may make it have a broader spectrum than another antibiotic. So essentially, all beta-lactam drugs work the same because they all have the same mechanism of action. What changes is this side chain. Are we good? Good. Okay. Now for the penicillins. The penicillins are classified into natural penicillins, penicillinase resistant penicillins, meaning that bacteria secretly release an enzyme to break down the penicillin, aminopenicillins, and anti-pseudomonopenicillins, by the name against pseudomonas. Let's start with natural penicillins. How I like to think of them is that they are natural, صح? Natural, benzene, petrol, that's natural. So it's called benzyl penicillin, okay? The spectrum is gram-positive cocci, anaerobes, and selective gram-negative cocci. You don't need to know the spectrum if it's not distinct. I just added it here for the sake of completion, but if a spectrum is not distinct, then you don't really need to know. Hatta natural penicillins, they're not used that much because they're not that strong. And they're destroyed by beta-lactamases. Beta-lactamases are enzymes secreted that break down the beta-lactam ring. If you don't have that beta-lactam ring, the antibiotic is no longer an antibiotic in this class, of course. And a way to remember it is how I said natural penicillins, petrol, benzene, benzyl penicillin. And natural stuff can be easily destroyed. Now, for penicillinase resistant penicillin, their examples are fluoxacillin, doxycycline, neficillin, and oxacillin. Now, there are a lot of variants of staph that secretly release this enzyme, penicillinase, that breaks down penicillin. Now, because of this, we need antibiotics. They're against this because what if a person has this infection? We can't just leave them to die. So the spectrum is effective against penicillin-resistant staph, not MRSA. MRSA is methicillin, okay? And how do you remember this? Don't fear staph. We have diclocillin, fluoxacillin, neficillin, and fluoxacillin. Fear, okay? And before we go, it's not mentioned here, so we'll mention it later. Aminopenicillins are actually like an extended spectrum of penicillins, which means that when you add the amino group, they cover more bacteria, such as gram-negative, gram-positive, and enterobacteria. And these are extended penicillins because of the amino group and it's extending it. So just remember, amino and ampicillins have a wider spectrum than the natural and the penicillinase resistant penicillins. Now, anti-pseudomonopenicillin, which is penicillinase sensitive, are tetracycline and pipercycline. They're anti-pseudomonal, which means they're against Pseudomonas. Now, how I remember tetracycline and pipercycline is that ticks and pipes spread in dirty water. Ticks is for tetracycline and pipercycline is pipes. Now, why dirty water? Because that's where Pseudomonas aeruginosa is found. And I don't think you took unconventional organisms, or it's not included in your midterm. But from Sketchy, how I remember it is this is the Mona Lisa. She's in a bathtub, and that's usually where Pseudomonas aeruginosa is. So I just remembered it: dirty water, bathtub water. This is how you can remember it. Moving on. Penicillins, pharmacokinetics. Now, most penicillins are excreted via the kidneys, via the tubular secretion. But what blocks it is a drug called probenecid. How I remember it is, you know how pro doesn't let you leave early and you're in that room for hours? Pro doesn't let you leave early, probenecid. Penicillins cross the placental barrier, but they don't have teratogenic effects. And patients with impaired renal function have their dosages readjusted, except for nefacillin and oxacillin, which is the ones that I wanted to mention, but I knew we were going to mention later. They take their own route. So how I remember it, and no, they say no, nefacillin, oxacillin, and for nefacillin, O for oxacillin, they take their own route. Are we good? Moving on. Adverse side effects, the most one that you need to know here, like as you can see, I put those in like a smaller handwriting because they're not that important. But the most common side effect is hypersensitivity reactions. That's the most common one. And if you're allergic to one penicillin, you're most likely allergic to all the other penicillins. And these are rare adverse side effects. You don't need to know them. This is just the one that you need to know. And if you're allergic to one, you're probably allergic to the rest of them. Now, I think you took this in one of the first 8 pharma lectures, that for an antibiotic to be effective, it has to, 1, bind to the receptor, reach the target, and be active. These are the 3 things that an antibiotic needs to do, right? So the mechanisms of action would be against these 3. So the way a bacteria can be resistant to an antibiotic is natural resistance. Some of them don't have a cell wall, so you can't inhibit the cell wall if it's cell wall synthesis if it's not there. And acquired resistance is the 3 mechanisms: inactivation of the antibiotic, not active; modification of the target, which is the receptor, so it can't bind; impaired penetration of the drug, can't reach the target. So it really like targets those 3 main points. So if you remember those 3 main points, you can remember how acquired resistance is. Now, how do we prevent beta-lactamase from breaking down the antibiotic? We have beta-lactamase inhibitors, okay? Because the bacteria sometimes secrete this and we don't want to break down the antibiotic. So there's 3 of them: clavonic acid, sulbactam, and tazobactam. Now, these are used in combination with the penicillins. So the penicillins target, it's like they're like a crew. I'm going to go beat the cell wall, you're going to go beat beta-lactamases. So they work together. And they present as a substrate to the beta-lactamase and engage it to give free access to penicillin. Like it's what's the word? Distracting it. Like when there's a villain there and you need to distract them so you can go to the target. They're irreversible inhibitors of beta-lactamases. And do you know that white medicine that your mom used to give you as a kid, as like the antibiotic? It's called augmentin. Augmentin is actually a combination of clavonic acid, the beta-lactamase inhibitor, and amoxicillin, which is a penicillin. So I just love this one because I hated this medicine as a kid and it just helps me remember it. Okay, moving on. You don't need to remember these. This is the only one that's actually significant. Now, moving on to cephalosporins. Cephalosporins are in generations. Before we get into it, they're in generations from 1 to 5. Their mechanism of action is that they inhibit the last step of protein synthesis. Now, the first generation is cephalaxin and cefazoline, okay? And how I remember this is that the first person there was Alex, and I'm Sudanese, and person is Zol, so cefazoline, cephalaxin. That's how I remember it. Now, second generation is cefaclor and cefuroxime. How I remember this is that, listen, I'm not a Taylor Swift fan, but my friend is, and this is how she remembered it, and this is so how I remember it. So, oops, ignore that. 2020 Folklore, which is an album that she made that was released in 2020. And it has an increased spectrum than the first generation. As you go down, the spectrum just increases as you go from first to fifth generation. Now, third generation is ceftriaxone and ceftazidime. Yeah. These are the most common ones that are tested on exams. Like I just remember third generation the most. The others aren't tested that much. This is just the one that's tested the most. And how I remember it is that it has tri and ta and tai, which is third. That's how I remember it. And it covers P. aeruginosa. So as you go down, spectrum increases. So right now it was a normal spectrum, then the spectrum increased, then first generation. Now it covers P. aeruginosa. Now moving on to the fourth generation, cefepime. Cefepime has a better activity than the third generation in regards to P. aeruginosa. And how I remember it is cefepime, the P, is for P. aeruginosa. And fifth generation, how I remember it, the spectrum is, it covers MRSA, but no activity against P. aeruginosa, which is weird, right? Because we were fighting it right now, and now it's going to MRSA. MRSA to me is the biggest villain of them, because vancomycin is always the choice for that. But now the fifth generation can cover it, wow. But it doesn't cover P. aeruginosa, so it's bipolar. So how I remember it is ceftobiprole and ceftriaxone. Caroline is bipolar. Two generations before covered P. aeruginosa, this one doesn't, so it's bipolar. That's how I remember it. Now, moving on to carbapenems. Carbapenems are epipenem and all these penems. I don't have to say the rest of them, but the one that you need to know is epipenem, and it's used with cilastatin. We're taking this drug right now in our block, but I don't know how to pronounce it. It's always co-administered with these because it is inhibitor of renal dihydropeptidase 1 enzyme, which is responsible for the hydrolysis of this drug. So this drug, as we know, it's a cell wall synthesis inhibitor, but its half-life will be significantly reduced if we don't use this inhibitor. So that's why we use it in combination. Now, it's active mostly against clinically important bacteria, including anaerobes. It's not destroyed by most beta-lactamases, and it's important in hospital empirical agent for life-threatening infections. Empirical means that you don't know what the infection is, but you're just trying to cover the most out of it. So this drug covers a lot of clinically important bacteria. So that's why we use it. And we only use it when we actually do know I'm sorry, I don't know, I just lost my train of thought. Ignore what I just said. Carbapenems, how I remember them, is carbohydrates, buns, which is like the burger, P, V, and S. That's how I remember it. So P is for phlebitis, V is for vomiting, N is nausea, and S is seizures. There's, again, side effects. You have to look at the most characteristic ones. There are not many characteristic ones in carbapenems, so I don't honestly think you'll be tested on any of these. Now, monobactams. Monobactams, like azithromycin, their spectrum is aerobic gram-negative. It's used in severe sepsis and in hospital-acquired infections. So just think hospital. In hospital, you think of hospital-acquired infections and severe sepsis. Its spectrum is aerobic gram-negative. Now, it has a very narrow spectrum, which is what I just mentioned, and it's only used if you know the infection, if you know what type of organism that's causing the infection. And then you use azithromycin. How I remember it is aerobic, zero trouble, aerobic, gram-negative, bacteria only, 0 gram-positive coverage, and tested only if sensitivity is known. Now, vancomycin is my favorite because this is the one that covers MRSA. The mechanism of action, how it works, is that, if you remember this from Dr. Henna's lecture, that there is this, I think this was a sugar, bactoprenol. It has the part that's growing and going to be put onto the growing chain of peptidoglycan, right here. Now, for this sugar to go all the way to the other side, it needs a thing to take it to the other side. What vancomycin does is that it inhibits it from going to the other side. It actually like binds to the last two amino acids here and prevents it from going to the growing chain. So it inhibits transfer of the unit by attaching to the last amino acids, alanines, and therefore interferes with cell wall synthesis. In other words, it inhibits peptidoglycan polymerization. It is effective against MRSA, which we all know by now, and it's given IV. How I remember it is van goes straight into, so a van, and vein IV. Adverse side effects, van, ho. So venous thrombosis, allergy, red man syndrome. This is very high yield. Nephrotoxicity, hypersensitivity, and autotoxicity. Now we're done with the first lecture. Bismillah, before we get into protein synthesis inhibitors. Okay. Protein synthesis inhibitors, before we go into the whole entire thing, let's think of the mechanism of action of protein synthesis inhibitors, okay? To make proteins, you need ribosomes. And these drugs target the ribosomes. So you target the proteins. Proteins are not made. Now, in bacteria, you have 70S ribosomes. In humans, you have 80S, so selective toxicity. They're not toxic to us. This 70S ribosome has a larger subunit and a smaller subunit, 50S, 30S subunit. Okay? Now, recap of protein synthesis translation. Okay? So first, we start with initiation. Initiation is where the mRNA binds to the 30S ribosome. And then it binds to the 30S ribosome, which is the smaller portion. It says on the image, yeah, the smaller portion. And then the initiator tRNA pairs here with the anticodon, with the start codon, the AUG, at the P site. This is the P site, A site, and E site. And it binds to it. And then the 50S subunit joins to complete the whole entire thing. And then that's initiation. We go into elongation, where the new amino acid acyl tRNA enters the A site. And in the A site, the peptidotransferase forms a bond between the amino acids. And then the ribosome translocates from the A site to the P site and then the E site. And that it just goes on and on and on and on. And then the last step is the termination, which is when it gets to the stop codon, and then the amino acid is gone. All right? I hope I made that clear. I don't remember protein synthesis that much, but that's what I remember from. Now, for the actual important part, classification of protein synthesis inhibitors. How I like to think of them is that they either inhibit 30S or they either inhibit 50S, okay? To me, the ones that inhibit 30S are the TAs, the teacher's assistants, tetracyclines, and aminoglycosides. The ones that inhibit 50S are the rest of them. The rest, chloramphenicol, macrolides, clindamycin, linezolid, quinupestrin, dalfapestrin. Okay? Okay. Now, aminoglycosides, the drugs are gentamicin, tropomycin, and amikomycin. How I remember this is GTA. Okay? These are the aminoglycosides. And GTA is crazy. Okay? So it's bactericidal. It's not bacteriostatic. Kills it directly. And the spectrum is aerobic, gram-negative rods. And aerobic because this drug only works if there's oxygen, and gram-negative because if you remember from Dr. Henna's lecture that this drug needs to go through the porins to get into the periplasmic space to inhibit the ribosomes. So that's how it works. Now, mechanism of action does three things. It binds to the 30S ribosomes, remember TAs, and it interferes with the initiation complex. And these drugs also cause misreading of the mRNA, but most importantly, 30S. There's a table at the end of your doctor's lecture anyway with the summary of all of this. I'm going to include it in the end for which they target. But right now, just remember with me 30S and 50S. Now, adverse side effects, how I remember them is NOM. So you need to go to sleep. You always want to go to sleep, but the TAs always wake you up at 8 a.m. to go to pro. So what are they? Nephrotoxicity, autotoxicity, and contraindication is mesenteric gravis, M. Okay? Now moving on to the pharmacokinetics, they have a post-antibiotic effect. So the antibiotic effect stays longer than it is. Like it stays in the serum longer to target the bacteria. How I remember this is that when you wake up early for pro at 8 a.m., you're still sleepy. So that sleepiness lingers, like how the effect of this drug lingers. And post-antibiotic effect is the presence of the antibiotic effect after the serum, long after the serum concentration has fallen below the MIC, which is the minimum inhibitory concentration, which is good because then the patient doesn't have to take the drug again. It leads to better compliance, less toxicity. Anyways, in patients with renal dysfunction, dose adjustment is required, and you don't need to know this. Macrolides. Macrolides, how I remember it, is that the oldest of the family is the macro, right? And the oldest of the family to me, because I'm the oldest of the family, is the ACE, okay? ACE stands for azithromycin, clarithromycin, erythromycin. Spectrum is unusual organisms. Again, you only need to know the distinctive ones, chlamydia, spirochetes, and mycoplasma, as well as these. Macro spectrum, big spectrum. Gram-negative, gram-positive, cocaine, rods, chlamydia, spirochetes, and mycoplasma. Mechanism of action is that it binds to the 50S, because it's not a TA, it's not T or A, and inhibits protein translocation. So it inhibits the movement from the A site to the P site, so the A site isn't available for the next amino acyl tRNA attachment. And adverse side effects, again, macro. I'm really milking this macro thing, but just bear with me. Motility issues, arrhythmia, which is so important. This is a very important side effects. This is tested on exams. QT syndrome, systolic jaundice, cholestatic hepatitis, and jaundice. It's okay in pregnancy and children. Reversible inhibition of cytochrome 450. Now, tetracyclines. Tetracyclines to me is a bicycle because they all end with cycline. Tetracycline, doxycycline, and minocycline. You also have mentioned in your lecture tigecycline, but it's its own class of drugs. Now, tetracyclines, we have tetracycline, doxycycline, minocycline. I remember them, they're just a bicycle because they end with cycline. They bind to 30S, again, TAs, and they prevent the entry of amino acyl tRNA to the A site. Their spectrum is broad, but the notable ones are protozoa, rickettsia, chlamydia, and spirochetes. Contraindications, don't give them in people who have renal failure except for doxycycline, and in pregnancy or children below 8 years old. And you'll see why in a second. Adverse effects, how I remember them, is that tetra is 4, and what has 4 credit hours, FND and CVP, okay? So F is for fungal superinfection, N is for nausea, D is for diarrhea, and discoloration of teeth, which is a very important adverse side effect of tetracyclines. Worsening renal failure except doxycycline, S difficile causing pseudomembranous colitis, and photosensitivity. The only one that you need to remember here, and I'm pretty sure is the one that is the side effect that discolors your teeth. And this is what it looks like. It's a chelating property of calcium. I don't know if I'm saying it right, but this is how the teeth will look like when somebody is taking tetracyclines when they're pregnant with a child. So you don't give this during pregnancy because the drug binds to calcium and it deposits in teeth and bones. So it's not given in pregnancy. Okay? Next is chloramphenicol. Now I need you to bear with me here. Again, they're not TAs, so it binds to 50S. It prevents peptide elongation and inhibits mitochondrial protein synthesis. How I remember this is that you see this guy, he's a 50-year-old man, okay? Reminds me of like my dad, because my dad always has a bag of chlor cleaning the pool. So the bag of chlor, bag is for the adverse side effects, hold on. Chlor, you throw it into the pool to prevent the germs from spreading, right? You prevent peptide elongation. 50 years old, 50S. Bag of chlor. Chlor is for chloramphenicol. Why bag? Bag stands for bone marrow suppression, aplastic anemia, and gray baby syndrome. The most important one that you need to remember is gray baby syndrome. This one's so repeated, and this is gray baby syndrome. They'll probably show you a picture of this, but this is how you remember chloramphenicol. Okay? Okay. Now the spectrum is broad and it's used in typhoid fever, staphylococcal brain abscess, meningitis, Rocky Mountain spotted fever. I just remember that these are crazy things to use a drug for because meningitis is in the brain, staphylococcal brain abscess is in the brain, typhoid fever and Rocky Mountain spotted fever are both fevers. So you just do this, like they're all in your brain. Anyways, it has good penetration in the brain. That's why it's used in abscess and meningitis, and it's not commonly used due to its side effects, which are major side effects. Now, clindamycin, okay, binds to 50S, not 30S, because it's not a TA. And its spectrum is anaerobic infections, okay? Anaerobic infections above the diaphragm. This is a normally repeated MCQ, and they ask you, like, for anaerobic infections, is it above or below the diaphragm? If it's above, it's clindamycin. If it's below, it's metronidazole. You're gonna take this in protozoa, I think. So how I remember clindamycin is that we have Linda, okay? Linda is clindamycin. She's in the office and she loves using PDFs, okay? She has mild to moderate acne and she's very strong. And because she's so strong and so hardworking, she takes everyone's breath away. So anaerobic infections, she's used for anaerobic infections, okay? Linda. PDF is for pseudomembranous colitis, fever, and diarrhea. She's really strong, so good bone penetration, takes everyone's breath away. It's used for anaerobic infections and treats mild to moderate acne because she has mild to moderate acne. Are we good with this? Okay. Linzaloid, okay? Linzaloid, she's very mad, as you can see from the red scribbling on her forehead. She draws maps and she draws the line. So linzaloid. She's 23 years old because 23S ribosomes binds 23S of the subunit of 50S. It prevents the formation of 70S initiation complex. She's very mad because she's resistant against stuff. So she's used for resistant bacteria like MRSA, vancomycin resistant Staphylococcus aureus, and vancomycin resistant enterococci. She draws maps because F is for myelosuppression, A is for altered taste, P for peripheral neuropathy, and S for serotonin syndrome. Now, quinipestrin and dalfopestrin. Now, actually, bear with me on this part. Quinipestrin reminds me of the band Queen, the British band, okay? Quinipestrin reminds me of the British band Queen, and dalfopestrin reminds me of Elvis Presley, because Preston Presley, and he's also a dad, so dalfopestrin. This is how I remember them, okay? Now, they're used together in combination, and Queen and Elvis Presley would make a good playlist. And they're also used against MRSA, Versa, and VRE, like linzaloid. So no one can resist them because they're very good. They're very worldwide. Everyone knows them. And they're used in a combined ratio of 30 to 70%. صح? 30%, just remember, the UK is smaller than the US. Elvis is American, Queen is British. Elvis, 70%, so dalfopestrin, 70%. Queen, 30%, quinipestrin, okay? And dalfopestrin binds to 23S subunit, and quinipestrin binds to the 50S subunit. How I remember this is that Elvis Presley was married to someone that is significantly younger than him, so dalfopestrin binds to 23S, okay? And adverse side effects, pain at site of infusion, myalgia, whatever. Celebrities in the past have used IV drugs for drugs. So this is how I just remember them. Like in the old days, celebrities in the past used to do this. So pain at site of an injection or infusion. And that's a recap of protein synthesis inhibitors. And now we can finally move on to the last pharma lecture, anti-metabolites. So the anti-metabolites are like drugs that are used as a substrate for an enzyme. They bind to that enzyme, but they don't necessarily do anything. They just bind there so that the other substrate won't bind. They render the enzyme's activity useless, okay? They don't let the metabolic process take place. And there's two kinds, sulfonamides and trimethoprim for this part, okay? Sulfonamides are structurally similar to PABA. PABA is a metabolite used in bacteria folic acid synthesis, okay? And this is PABA, and it combines with petridine to make dihydropetroic acid, which is an early precursor of tetrahydrofolate, which is folic acid, okay? So sulfonamides bind to this enzyme that catalyzes this reaction. So it binds that enzyme, so PABA can't bind anymore, and we can't make dihydropetroic acid, meaning we can't make folic acid. So that's how it works. Okay, this is the mechanism of action. Now, pharmacokinetics. Pharmacokinetics is that they're orally absorbable. This is the most important one. I watched Hatouf's lecture for this to make sure I didn't miss anything, because we didn't have Hatouf, if I remember correctly, Dr. Hatouf. They're distributed widely in the CNS and placenta, but the only thing I think you need to remember is that they're orally absorbable. And they're metabolized in the liver because a large portion of the active drug is not completely broken down and it's excreted through the kidney, making, yani if you think about it, if it's active and it's in the kidney, then that means it could treat infections in the kidney. So it's used to treat UTIs. Adverse side effects are crystalluria, fixed drug interactions, Stevens-Johnson syndrome, hypersensitivity, photosensitivity, megaloblastic anemia, and hemolysis in G6PD. So megaloblastic anemia, I know what you're thinking. Isn't this for bacteria? Why is it inhibiting folic acid synthesis in us? That could happen. So it could result in megaloblastic anemia. Stevens-Johnson syndrome is just like a widespread allergic reaction. The person looks red and it's very shiny. Their skin looks very shiny. Fixed drug interactions are a type of drug interactions. They're cutaneous and they're like in the same place. So you take that drug and the side effect appears in the same place over and over again. So every time you take that drug, it appears there. And G6PD deficiency hemolysis is because the patients with G6PD deficiency are prone to undergoing stressful conditions when taking sulfonamides, so it leads to hemolysis. Now moving on. They're contraindicated in pregnant women because pregnant women need to take folic a lot. So if you're inhibiting that is not good. And you shouldn't give it in patients less than 2 months old because sulfonamides displace bilirubin from albumin, which could cause something called kernicterus, which is, the image is not loading, but basically the bilirubin accumulates in the brain of a child less than 2 months old because their system is not well made yet. So it displaces it and it causes a problem in their brain. And this is fixed drug interactions, again, cutaneous, they're on the skin and then they just reappear on the skin every single time. Now, trimethoprim. Trimethoprim is similar to sulfonamides, but they actually inhibit this enzyme instead of this enzyme. So it's at a later stage in folic acid synthesis. They compete for dihydrofolate reductase. So they compete with dihydrofolic acid by rendering this enzyme inactive. Then you can't make tetrahydrofolic acid, which is the active form of folic acid. Now, pharmacodynamics about trimethoprim, it's a weak base, picks up proteins in acidic environments, which means what else is acidic in the body? It's most likely the prostatic and the vaginal fluids. So it accumulates in those regions, meaning that it could be used in UTIs because if they're going to accumulate, might as well treat an infection there. Trimethoprim and sulfonamides are used in combination. So it's like best of both worlds. I'll inhibit an earlier stage, you inhibit a later stage. I'll inhibit dihydropetroate synthase, you inhibit dihydrofolate reductase. And the optimal ratio is 5:1. Sulfonamides 5, trimethoprim 1. And how I remember it, and it's a later stage, so still we didn't get to the final stage, the number 1 stage. So just remember it like this: sulfonamides up here, trimethoprim there. Okay, now you could kind of combine trimethoprim, I didn't mention the name of it, trimethoprim and sulfonamides to make a drug called cotrimoxazole. And this is what we use, okay? Now, how does its resistance come about? How do the bacteria learn how to be resistant to this? It could either mutate the dihydrofolate reductase or acquire a mutated version from a plasmid, which would then mess with the drug inhibiting this. And then synthesis of altered dihydropetroate synthase, again, sulfonamides can't bind to, they would have a lower affinity for this. So this is the way bacteria can become resistant to cotrimoxazole. Cross resistance among all. So if the infection that you have is resistant to this, then it's most likely resistant to all. Now, when do we use it? We use it in toxoplasmosis, pneumocystitis, pneumonia, which is a fungal infection, urinary infections and respiratory infections, and in malaria. Adverse side effects is folate deficiency, megaloblastic, and blood disorders. Now, just remember folic acid, it would be megaloblastic anemia. Other combinations include these. You don't really need to know this, I think. I don't remember ever being tested on it, but just in case. Now, for the final part, quinolones. Quinolones are in generations, just like cephalosporins. The first generation is nadilsic acid, and then the rest of them are fluoroquinolones. What does that mean? That means that there is a fluorine group added to them to increase their spectrum or their activity. So the first generation, after the first generation, fluorine groups are added, and they all end with oxycillin, oxycin, except for the first generation. Now, how I remember them is first generation naldosic acid khalas. Second generation, new champions, new for norfloxacillin, champions for ciprofloxacillin. Then you level up for levofloxacillin, and then finally the grand masters, so gemafloxacillin and moxifloxacillin. And they're used for the treatment of urinary tract infections, except for moxicillin. Now, their spectrum, as you can see here, it goes from gram-negative to gram-positive, if you notice the trend as you go down the generations. So this is just a way to remember them. You can see that as you go down, it goes from gram-negative to gram-positive. Pharmacokinetics, don't drink milk when you're taking this drug because it has mild chelation effect, just as tetracyclines. They cross the blood-brain barrier and can penetrate immune cells, which is helpful for to concentrate the antibiotic at the infection site. Cross the blood-brain barrier can treat meningitis. Now, contraindication is pregnant women and lactating women. Why? Because this drug can cross the placental barrier and affect the baby's growth. Fluoroquinolones inhibit topoisomerase 2 and topoisomerase 4. 2 is for the gram-negative bacteria, 4 is for the gram-positive bacteria. Us humans, we also have topoisomerase 2, but it has a low affinity to fluoroquinolones, so we don't have to worry about that. Topoisomerase enzymes are the DNA gyrase enzymes. Remember when you uncoil the DNA strands and then the supercoiling happens, so you need to cut them so that doesn't occur? Well, this drug inhibits those enzymes, so supercoiling does occur. When to use urinary tract infections, respiratory tract infections, bone and joint infections, and meningitis. Now, the adverse side effects is damage to growing cartilage, Achilles tendon rupture, which is a common side effect of ciprofloxacin, central nervous system effect because it crosses the blood-brain barrier, and it increases the QT interval and inhibits P450 enzyme. And that is it for the PAL session. Good luck on your midterm. I hope you do amazing, inshallah. And if you have any questions, don't hesitate to contact me. There's my number and my email. And please don't forget to leave your feedback. Thank you.